Hey everyone, good morning. It's Ann Ogden here in Albany today with the gang here, and Jim and Megan are in New York City this morning. So again, we're at two ends of the, not complete ends, but across the state. So, and we will get started as soon as I can advance the slide. Good morning. Here we go. All right, it worked. We are at day 26. Happy 26th day of launch. So we hope that things are getting better out there and more stabilized. We continue to work on eliminating any of the roadblocks and technology challenges that are in front of you. And we will have some updates throughout the webinar on where we stand with that. For our agenda today, we will talk about, I want to just reiterate, because I know even last week we didn't have as much participation as we do this week, which so good, our numbers are growing. And we know a lot of that was due to technological challenges. So if you were not able to participate in last week's webinar, it is on the Litmos platform where you go. That's where you log in to get your training. So the recorded webinar is there, and we will continue to post these recorded webinars there on a regular basis as soon as we can get them up and going. Sometimes it's maybe a day lag, but if you check back, it should be there. So we'll talk about, again, the webinar expectations, technology, caseload assignments and flexibility, billing, translation, choices in ePaces, and Paycom. Whew, sounds like a rip-roaring rockin' time this morning. So according to go over the expectations with the webinars, they are for you. We work really hard to try to put together information that is meaningful and timely for all of you. It's pretty apparent sometimes of the people who don't chime in because we get questions after the webinars of the things we've covered. So we've started to be a little bit more direct in saying, why don't you listen to the webinar? Because it's hard when you do the webinar and then you have 25 people ask you the same question you just covered. So we spent a lot of time trying to put this together and hope that the information is helpful, but we also need your cooperation and kind of listening to it and chiming in so that you get the information. So supervisors, please, it is your responsibility to make sure that the people that you oversee are attending the webinar. I know there are sometimes problems, and I know maybe our entire workforce isn't free at 9 a.m. on a Thursday morning. But if there's an extenuating circumstance or a schedule, you have a part-time employee, it's still their responsibility to make up the webinars, and it's your responsibility to make sure that they do. So please, whatever system you want to put in, I don't need to see sign-in sheets or anything like that. Maybe you need to see a sign-in sheet or an attestation. It's up to you of however you want to manage the people that you support and making sure that they are regularly attending this webinar, and also one of the webinars on training, either the Tuesday one or the Thursday one that Lori Liptak and her crew and Nancy Shea put together, so that again, those are tailored to the questions that are coming up in the field and what's most important to all of you and for all of you. So for technology challenges and resolutions, we are working through, we only have a small number of sites now with some significant Wi-Fi issues. I know Jim Brown and his team are working at deploying adapters so that you can log right into hardwiring into the internet in sites where that is not a possibility. There's a crate, it's called a Cradle, and that is kind of like a hotspot on steroids, a mega booster, so that you can have connectivity with the internet. And I think that is able to be launched by maybe tomorrow or early next week at the very latest. And we have 5 sites that are high priority that we have slotted for getting that equipment, and we can continue to to launch that in other sites as well, if we determine that there is a need to do that. Chromebooks, like I said, the adapters should have been deployed, or they are being deployed at this point, so that those adapters allow you to hook in. Those adapters allow you to be able to put a thumb drive and download information, or download information onto a thumb drive to then go up into Metasced. So we know that people had a variety of ways that you and your former organization saved documentation. So these adapters are a way for the Chromebooks to have kind of an external port, so that information can be uploaded and downloaded, and we kind of open up that security for a temporary point of time, because we know you need to get access to your files. Most sites will have one of those adapters, which you can share to do that. Some sites have more than one adapter. It's really with the IT team to figure out the needs of equipment and to deploy that. And printer scanners, I think that is winding down. I think all sites, if maybe there's one or two stray sites that doesn't have a printer scanner. I know some of you may have them, but they're not working appropriately, or they haven't been set up. So I know IT is aware of that. Or maybe they're not. So again, if you continue to have technology challenges and need assistance and resolutions, reach out to your care manager, regional director, Megan, Danielle, me, Jim, all of the above, in terms of the intensity and the need of what's going on. And we will try to support you and to eliminate that obstacle to the best of our ability. All right, service provision expectations. Jim, I think you're on with this one.
Hi, everybody. So we want to make sure, again, we've kind of covered this. We think this is important to cover virtually every week, that you document your services when you deliver them. I know some of you may, again, we've talked about this before around, historically with MSC, it was a different process. Even though this is a monthly service we're billing for, we have the ability to bill weekly based upon when you deliver services and document the services, and the supervisors approve the activity and the service. So the thought is that you're delivering the services and you're documenting those contemporaneously, which is really shortly thereafter. Supervisors are approving on almost a daily basis. And we know the month is coming to an end, and we're going to talk a little bit about where we are in terms of in the next slide. But the expectation is that, with the challenges, we know that we've had that, but we really need you to get your services into the system, documented as soon as possible, and that you must deliver the service by 7/31. Our next billing cycle, and that's what that's tied to, is next Tuesday, and when the claims are gathered for submission to Medicaid for payment. And we've said this before, every person you support should have a minimum of at least one service per month. That should not be a challenge this particular month, other than maybe you can't reach a person. But the point is, you needed to have reached out and to everybody that you're supporting to touch base with them minimally. That should have really already probably happened. And as we've discussed before, individuals with Tier 4, which includes Willowbrook, but we have a number of people, I think it's about 900 that are Tier 4 that are not Willowbrook, that require face-to-face contact every month. And as we've talked, and as you know, Tier 1s through 3 require quarterly face-to-face contact, which could occur at any point, during the months in that quarter. And again, we always remind, and Lori has trained on this, always check the in-person box when you complete a face-to-face visit, because if you do not do that and just write it into the note, it's not going to be, the system will not pick that up as having completed a face-to-face visit. So that has to be checked. One of the other major issues that many of you had brought to us is the Tier 4 group. That's about 900 individuals or so. That a lot of questions about how people got into Tier 4. Many individuals and families may not want that level of monthly contact that's required with Tier 4. We initiated this. Care Design had initiated this issue with OPWDD. And also had support from the other CCOs on this issue of providing more flexibility on Tier 4, with trying to give individuals and families more input as to whether or not they should be in Tier 4. We had a meeting with the state a couple of days ago, and they made it very clear to us that the methodology that's been approved and expected from CMS by the federal government, they cannot change the rules. So the requirement is the methodology is the methodology. So people in Tier 4, we have to comply, which means we have to have everybody move to a 1-to-20 caseload within 90 days. That's the state's expectation. That's what the federal government's expectation, and that's what the Department of Health's expectations are. So unfortunately, we do not have any real wiggle room here. The only option would be for somebody, for an individual or family or the decision maker, to opt out of health home and move to basic if they don't want that contact. Now, that being said, families can refuse the contact every month. So in other words, they could stay in health home care management, but refuse to have the face-to-face. What that puts us in a position of just not being able to bill. And that's a challenge for us, even though on top of that, we have to get to the 1-to-20. So obviously, we're going to need you to do the best you can to try to find a way to conduct the face-to-face as much as possible. Many families don't want people in their homes every month, so maybe there's an alternative as a way to do that, particularly with children. If they're in a rec program, respite program or something, some ability to do that as much as possible, but we're not going to get any leeway from the state on this. The only thing that we will evaluate and have the ability to potentially change is the date that this is required to be compliant with the ratio of 1-to-20. Right now, it's still 90 days, and that's our expectation, that we're looking at this to come into compliance within 90 days, which means by the end of September, we have to have dealt with this. For Care Design, this means that we probably have to hire anywhere from 20 plus staff just to deal with this. And it also means that a number of individuals and families are going to lose their care manager. And we're going to have to decide, as individual staff have to go down to 20, what's going to happen to the other number of people they currently have on their caseload, and they're not going to be able to retain the same care manager. So that's a real challenge that goes against a commitment we've made to individuals and families, but that's the rules. So we don't really have, unfortunately, the state has said they do not have any wiggle room with this, with DOH or with the federal government. So we're kind of stuck there. So sorry about that. There's not much we can do. Okay, on to the next slide. Oh, I'm sorry. Go ahead, Ann. We're going to do this?
No, I'm adding that one, and you can cover this one too. This is the one I added in the middle, so it's right in the middle of your slides. Do you want to?
Okay. So recruiting. This is, we've been, the HR department has been hard at work trying to help deal with our shortage of staff. In addition to holding the fairs several weeks ago, the job fairs, we've continued to advertise and push to hire additional care managers in particular in various parts of the state where we know we're short staff. So we are hiring, of course, and one of the things that we have been talking about internally, and I'll give credit to the team for coming to me and saying, we've got to come up with some other potential ideas on how we recruit. and how can we really beef up our workforce in a meaningful way. And so the staff have come to me and said, you know, what if we ended up doing something like an employee referral stipend? So in other words, you make a referral, and it has to be somebody that, you know, you actually went out and got to come to us to submit their resume for potential employment with us. And then we would provide and again, this is just sort of we haven't nailed it all down yet, so you'll get more information on this, but we would provide, to the extent that we end up hiring the person, and there'll be a period of time in which they're expected to stay with us before we actually would pay the employee who made the referral the stipend. We might make a partial payment of that and then pay the balance once the person that came on that you referred had met the time period requirement of how long they've worked for us at Care Design. So this is something that we're going to roll out probably, and Ann, you can jump in, probably next week or so, and we'll have more details about how it's going to work. But this is, again, we're really we hear other agencies have used this kind of concept, and it's been successful in trying to bring more people into the workforce. So again, so we're gonna look to roll this out next week. So you'll hear more coming from you know, from us on this in more detail.
Thanks, Jim. Yeah, two things. It's only going to be for care managers. So this is referrals for care managers, not for, you know, director level or other positions within the organization. And it'll start, we will launch it probably even tomorrow or Monday, Tuesday at the latest. So we'll put out the information for everyone. It doesn't count for anyone who has been previously hired or is currently being vetted. It'll like start effective whatever date, and then it'll be time limited to end on another date. So we'll make that really clear to people. And we hope that this is something that incentivizes. We hope to give enough so it'll incentivize you to really search who are your connections, who have you worked with, who's been great that might make a great addition to our team. So more information to come out very, very shortly. So check your emails for it.
Okay, so billing. This is sort of a interesting chart. The finance team put this together. What this chart is attempting to do is to show, you know, how many members we support, how many folks have we billed for, how many folks we've not yet billed for, and it actually breaks it down in showing by the count of care managers how many have where they sort of are in terms of percentage of folks that they support that they've actually put forward, which means they've done billable services for the individuals they support. So just to go through one of these as an example, so we have we have 69 care managers that have yet, who are covering about 1,500 members who have yet to submit a claim on behalf of anybody they support. Now, there could be some reasons for that, but these are care managers that have zero services provided that are reflected in Metasched. So that's a challenge. So what I'll say about that is that we are going to be providing reports to the regional directors, Megan and the team and the regional directors, and this will filter to everybody, that actually we know who the 69 people are. In this example, 69 people are, who they support, and we'll have to get to the bottom of this in terms of what's going on. So we have this for, as you can see, the breakouts of the range. So we have, you know, the next range is 1 to 24%. And as you look at this, you can see for those 112 care managers, we've only submitted claims for 513 people, which means it's closer to the 1% than it is to the 24%. So we have a lot of folks that, again, in that category, again, another 112 that have not provided what appears to be a lot of support to the individuals on their case. In fact, zero support for a number of people. So that's what this is attempting to show you. Now, the good news is we've submitted claims for over 13,000, almost 14,000 people. And some would say, well, that's great. The problem is we've got 26,000. So, you know, and as an organization, we need to have reached out to everybody. So this month, you know, and you may have done that, you just haven't documented it in the system. It's important. And I know there's been challenges with in some locations with the equipment or getting access to Metasced or whatever it is. But hopefully you've documented all of this, even if it's on paper, so that you can go back into Metasced when you can and get that in there. But we have over 12,000 people where the system is identifying that we have not provided a service yet in this month. So that's a real challenge for us. And think about it, we have a workforce of almost 900 or so people, a little less than that at this point. Obviously, these numbers are as of a point in time, but you know, so the expectation is that we're providing the services. So we've got a lot to do in the month. It's July 26th, right? July 26th. So we've got a lot to do in a short period of time. And we kind of covered the documentation previously. So this is very important, not only from a billing perspective, but from a support perspective to the individuals that you have and are supporting. So we really need you to get that completed and into the system.
Okay, thanks, Jim. So we wanted to cover interpreting services a little bit because I've received some feedback which is pretty concerning. And again, people may not realize the sensitivity or the importance. I'm going to give you the benefit of the doubt, but let people know right now how important it is. There are many of us, and myself included, who receive voicemails or sometimes emails. I get a lot from the website that are not in English. That especially needs a special attention. It is someone who is trying to reach out to us that obviously doesn't understand the voicemail system well enough, and they may end up in your voicemail box, or they may be calling you. Again, this is, I think, primarily at office locations, and people have received, it may even hit our corporate woods and our New York City office locations the heaviest, because that's where a lot of our phone traffic goes through. But if you receive a voicemail and it is not in English, it is your responsibility to make sure that you get that voicemail interpreted, that you either work with a supervisor to help you. Christina Cunningham is going to provide some information for us on the resources that are available to us, but do not just delete it and pretend it didn't happen. Because these are people who need our support, and we have made a commitment to support people that English is not their first language, or they need additional support in understanding our service system. So this is very, very important, and I can't underscore that it is all of our responsibility to make sure that we understand what the person is trying to communicate to us, and that we get them linked up with the appropriate support. So with that said, I'm going to turn it over to Christina.
Okay, thanks, Ann. Good morning, everybody. So in the event that you do receive a voicemail that is not in English, I just wanted to make sure that everyone is aware that Geneva Worldwide can help with that. So in order to use that, you do have to be registered with OPWDD. So if you think that you might, encounter that issue or need that service, please let me know. If you do get a voicemail that is not in English and you're not registered with OPWDD, you can always contact me. You can give me a call, and I would give you my extension number, but I think it's 100400.
We'll keep talking.
Okay, Ann's gonna look it up. So please feel free to reach out to me, and I can kind of walk you through what to do. But we have done this successfully with Geneva, and they're happy to do it. The little catch there is that you kind of have to make a guess as to what language it is if it's not really clear. Most of our callers, I think, who are not English speaking, are Spanish speaking, but that's not, across the board. So you just make your best guess. And the process basically, if you do have access to the system already, is to contact Geneva, just make a call to them like you normally would, and let them know that you have received a voicemail that's not in English and that you would like assistance with interpreting what the voicemail says. And you can tell them what language you believe it to be. And then at that point, they'll connect you with an interpreter just like they usually would. And once you get the interpreter on the call, if you're on your iPhone, you can either use your three-way calling feature, or if you're on your desk phone, there's a conference feature. And I would encourage you to get familiar with that if you don't know how to use it. But basically you push the conference, you select the conference selection, and then you go ahead and dial into your voicemail. Once your voicemail is, picking up and you're getting into your voicemail messages, then you hit the conference button again, and it should pull together your voicemail recording and the Geneva Worldwide interpreter. Okay, and then they might have to listen to it a couple times to get all of it, but that's been really helpful so far to us. So I'd encourage you to get familiar with that. It is a little intimidating to use the Geneva Worldwide system initially, but once you've done it a few times, those of you that do have to handle it, it does become a lot easier. And just a couple things that when you are using interpreting services, it's really important, whether you're on the phone with somebody or you're in person with them, that you are using terminology that is not terribly specific to, say, OPWDD or something like that, because some of those words just don't interpret. Some of those concepts culturally don't exist. So, just kind of keep that in mind. And the other thing is to please, make sure that when you're speaking through an interpreter, that you're actually speaking to the person. The interpreter is just sort of there in the background. So you're not talking to the interpreter saying, please tell the person, X, Y, or Z. You're actually telling the person and speaking to them directly. And then you pause, the interpreter will interpret, and then you'll go on. So it's a really helpful system. And if you do need assistance with that, please reach out to me and I'm happy to help you.
Thank you very much, Christina. So the next one is on to Megan. Take it away, Megan.
Okay. Good morning, everyone. So I'm going to go over some other important points that we really need to be focusing on, in particular, the July 31st checklist. And just as a reminder, this is extremely important. It is due by the 31st, which is early next week, I believe Monday. And it must be done for each person that you support and documented in Metasced. And I know we've talked about it a lot, but we really need to push the fact that that's just a critical task that everyone needs to be doing for each person on your caseload. So the other focus we need to have is on pre-assigned individuals. And these are the individuals that OPWDD is calling preliminarily assigned because the MSC agency that had worked with them did not complete the process to enroll the individuals before the June 30th, 2018 date. So as a reminder, it's our responsibility to ensure that the service selection is done and the enrollment with the individual and family. And we did, of course, have a very large number, over 900 people in this designation. And we do have to report this back to OPWDD. So this is a focus that I know many of you have some new people that are in this category that we've assigned to you. And if you have any questions, please work with your supervisor to make sure that we have the appropriate paperwork, consents, etc. Completed. And if they do choose another CCO, then we will be taking steps to make sure that they're removed from our roster. Okay, next slide.
I'm trying. Technology does not like me.
Hey,
all right, there we go.
Oops. Okay.
Yeah.
So switching gears on employee timekeeping. One of the things that we want to make sure that everyone understands is that in Paycom, there is a GPS feature. And this comes through on the Care Design New York iPhones, and it must be activated or turned on. Do not turn it off. That is a required part for us to be able to pay everyone. If someone goes into deactivate it or turn it off, we will look to having to address it potentially through the disciplinary action process. So please make sure that that is something that is kept on through the Paycom app on your iPhone. And the other thing is that it's extremely important to verify timekeeping for billing. So that goes hand in hand really with why we have this set up. And, you know, we want to be transparent. We know that's what everybody wants to do. So please make sure to not deactivate it. I know that maybe some individuals have, and if you have, you need to take steps to make sure that that is turned back on.
Is there a way of us finding that out?
So thanks, Megan. I just wanted to reiterate, when I was working on the slide last night, I played with my own iPhone, and it was, if for some reason you're confused, if you Google how to turn on the GPS setting, it'll let you know. It's very, very easy in settings under privacy, and then location services on. So we're going to be doing some auditing on this, and with the punches that you do, and it does tell us if you have it turned on or turned off. You can log in from your computers. It tells us the IP address, so that's fine. But you need to have this on. This is a responsibility that we have committed to in terms of what we're doing and how we can verify that people are doing the face-to-faces and actually where they need to be, and that you're logging in and logging out where you need to be. So this needs to be turned on. So thank you. Thank you for your cooperation. If you struggle with it, see a teenager or the internet, and they will help you turn it on. And Lisa has one more thing.
Yeah, I just want to add one more thing. I know that there are some employees that are using their personal phones. They've downloaded the Paycom app to their personal phones, and they may not want to have the GPS locator turned on their personal phone, and that's fine. Just don't use your personal phone then for clocking in and out. Please use the Care Design iPhone that's been issued to you for that purpose.
Thank you.
All right, now I'm turning it back over to Christina for choices.
Okay, everybody's favorite topic. So I'm going to start with good news, which is that we are now up to 316 users that have been given access. The bad news about that is that many of you may not have been notified yet that you have access. That seems to be sort of sporadic coming from OPWDD. So what I'm doing is checking access and notifying folks. So those of you that have been given access this week, I will send out a list and let everyone know that you are should be up and running. Which brings us to other issues with choices. So a lot of you have been having issues with going through the account setup process once you know that you have choices access. If you have not received notification that you have access to choices, please don't try to do the setup process. It is not going to work. I get a lot of emails from people saying, I tried to set up my account in choices, but I'm not able to get in, and so on and so forth. And what ends up happening is I go and look back and I try to help the person, and then I go and look back and realize, oh, we never got a form from you to request choices access, or you haven't received choices access yet. So rest assured that when you do have access, you will either be notified by myself or OPWDD. Unfortunately, it does require being patient. It is a lengthy process. As you can see, we only have 316 people out of the 600 plus that we have submitted. So, but they are coming along, so that's good. IT is working with OPWDD on a solution that should be able to smooth out the process for people to more easily get into their accounts and to have a more consistent experience using choices on their Chromebooks. So stay tuned for more information about that. There are some compatibility issues with browsers. What works for one person is not working for others, and things like that. So there's a wide variety of issues. So if you have requested choices access, again, be patient if you can. We will let you know when you do have access. If you previously had access, through your old agency, that account is likely to still exist unless your agency has actively gone in and removed your access or requested that it be terminated. Okay, so you might have some functionality, though, maybe limited through that account. Lastly, I am sending out lists, like I said, of approved users each week so that the regional directors can see who has access and can connect people with each other if someone, one of your coworkers has access and you do not, and they can assist you in getting some information out of Choices. As a reminder, we are not supposed to be sharing login information, so we don't want to be just sharing everyone's, giving people your username and password if you have Choices access. But you certainly can look up information for them and share information that's there. Okay. If after you've been notified that you have been given access, you're still having issues, please go ahead and put an email out to OPWDD through the web address that's on the slide. Or the email address that's on the slide. I understand that there is some confusion at OPWDD about who's supposed to get these. The FAQs that they like to point us to say to contact external provisioning, but now external provisioning seems to be telling some users to contact the CCO implementation team. So we're trying to iron that whole thing out. So in the meantime, go ahead and email external provisioning. My hope is that as they see more and more issues come through, that they might actually take some notice and help us out a little bit more. Okay. ePaces, we are setting up access for people who have requested it. Eventually, we'll get everybody set up that needs it, but at the outset, I had put out a call to supervisors asking them to identify folks that need access sooner so that we could do that. So I am working through those lists, and I thank you for those of you that have responded to that. If you have not been contacted about ePaces access, I want you to know that I have a lot of people that I have set up access for that I need to send out their login information. It's a one-at-a-time process, so it is, while it is in our control, so it makes it quicker, it is a little bit time-consuming to do because it's by user, and I really have to track it carefully so that we make sure that people are being accountable, or I'm holding them accountable for their access. When you do get ePaces access, I will send you an email. It'll give you your username and a temporary password, and it will also give you a link to access the system. And I will also provide you with a link to the eMedNI training calendar. It's very important if you're not used to using ePaces, or if you did not have access to it before, or even if you just want to know a little bit more about what you can do in the ePaces system with your access. I would encourage you to register for the MEVS training. MEVS stands for Medicaid Eligibility Verification System. And you will need our MPI to register. I have included it on the slide. Please jot it down, put it in your contacts so that you have that should you need it. But you will need that to register for those trainings. The trainings are provided both in person and by webinar. There's no need to attend in person. You can simply sign up for a webinar the next time that one is available. If you do not think that you're going to be using ePaces immediately, please don't ask for access right now. But we would like to get everybody eventually set up with ePaces access and knowledgeable about how to use it. So, tuck it in the back of your mind and maybe speak to your supervisor about whether or not, they feel that you have the need to do that.
All right, thank you very much. The next slide is let's hear from you, and we do have many, many questions, but I know we have a couple of other things that we talked about adding after the PowerPoint presentation was put together. So one of them is an update. Lori Liptak met with some representatives from Metasced yesterday to address some of the significant challenges with the Metasced platform, and has some updates on how that meeting went and what things we might see addressed.
Yeah, thank you, Ann. And thank you all for your patience in me not getting to your emails over the last couple of days to answer your questions. We did spend some time with our care managers and our supervisors and the Metasced team yesterday, and the care managers and the supervisors were fantastic. They pushed Metasced on some of the issues that you're seeing every day. I'll go over them really high level here. We'll talk about them more with the supervisors in the call at 10:30, and then hopefully you'll be seeing some changes soon. So I have some good news and I have some not so good news. The good news is Care Design, care managers were ahead of the other CCOs in identifying issues. You guys were the first to find them. So kudos to you guys. You're a fantastic team. Saving notes really quick. A lot of people have been emailing me saying they can't save their notes. They're not showing up on their calendar. Please check the time of 12 a.m. by expanding your calendar. If you did not change the time, it's going to show up as 12 a.m. And when you look on your calendar, you're not going to see it. So that was a little thing we couldn't figure out what was going on, and that's what it was. That part about the notes, the task notes that are sitting in limbo, where the care manager can see it, but the supervisor can see it, and you can't uncomplete it, you can't do anything. The team was able to identify the software glitch yesterday, and they've corrected it, and that should not be occurring anymore moving forward. The bad news is those notes that are sitting in limbo, although they are saved in the system and you can open them and you can see them, we can't bill for them. So right now, as of today, you're going to have to rewrite that note. The good news is you can copy and paste your text from a comment section, say onto a Word document, and then paste it back into a new note so you don't have to write it all over again. But if it's something you want to bill for, unfortunately today you're going to have to write a whole new note. Luckily, it happened in a short enough period of time that maybe it's not a lot of notes for a lot of people. So good news, bad news on that one. We saw and demonstrated all the issues you are having on editing notes and or forgetting to put in person, and they have made a request very quickly that be corrected, and that you have more flexibility at editing notes for the billing process, so that should be occurring in the next day or two. The progress reports, the care manager progress reports, Metasced is aware of the issues of the face-to-face not showing up. Supervisors, please work with your staff if they're saying that they completed a billable issue and it's not showing up on the report. It's probably because it's one of two reasons. One, it didn't save, or two, it didn't happen. There might be a third glitch. We're still trying to identify that. And finally, everybody's been asking about the IM assessment, so I have some great news on that. Metasced fixed the accessibility issue for us on how to access that. It was tested by our IT team. It is being tested by care managers this week. Hopefully, we'll give you guys the go-ahead on Monday to go ahead and start to use it and train on it. For those of you who haven't attempted it yet, next week's training will be on the IM assessment. If you have an IM assessment that's coming up very quickly, you are welcome to go into the super user training file in Litmus and listen to Jan Abelseth's presentation on how to do the IM assessment and what's to do for it to get you prepped and ready, but more to come on the instructions on how to do that, and the training will be next week.
All right, thank you very much, Lori. Jim, did you have a couple of things that you wanted to cover before we get to questions and answers?
Yeah, very quickly. I just wanted to mention that we had talked at previous sessions about Care Design from an organizational perspective, becoming a tax-exempt organization. We have virtually completed the application. It's a daunting application, having looked at it with our attorneys. It is virtually completed. I've already signed the documents. Our plan is to have that submitted either today or tomorrow to the Internal Revenue Service. It will be retroactive for those of you who particularly are in the loan forgiveness program. It'll be retroactive to prior to July 1st, assuming we will get approval, which our attorneys are pretty confident that we will get approval. So the good news is that the application is going in. It's very possible that the process could go, and this is considered quick, where we could have the status change within 4 to 5 months. That would be considered quick. If it goes into another pile, it could go 9 months. It could go up to 9 months before approval. And as I said, it will be retroactive. Any approval will be retroactive to prior to July 1st when you came to work for Care Design. So for continuity for that program, you will be all set. So that's not going to be an issue. So I just wanted to let folks know that that's been had been worked on, and we're on the home stretch for submission today or tomorrow. So that's all I had, Ann.
All right, great. If you want to keep your mic open, then we can divvy up and respond to the questions and answers. So I do have some questions or comments that have come that we're cutting in and out, and that it's hard to follow us, and I understand that, and I appreciate you continuing to give us that feedback. I think we might try to pursue initiative to make sure that we are hardwired when we're doing the webinars. I think because we're all on Wi-Fi, at least the New York City and the Corporate Woods office, because we're on Wi-Fi, we will continue to work on that and see if we can get better at that so you're not missing little pieces of what we're saying. This might be a question that Lori could answer. When working on case notes in Metasket Coordinate, are we able to write our own activity?
You should be choosing other as your task and then filling out the information in the comment section.
Okay. But they should try to choose an activity that exists first.
Right.
That's just a workaround, because if you choose an activity that it exists and is in the dropdown, which we are all working on limiting that dropdown, which is a little bit, well, it's very much unmanageable at this point. It's better to be able to be consistent and have it under something. But if it falls outside the scope of the dropdown, you can choose other. Many questions about adapters so that you can have keyboards and mice. Jim Brown, our CIO, is putting together a proposal so that we can look at that and figure out how and how many we may launch within the field. We know we've received that feedback loud and strong, so we will be reviewing that today or tomorrow at the latest, and having making a decision on what other equipment we might launch out into the field. The inbox isn't reflecting in the care coordination progress summary, even if it's been checked. Is this a glitch?
There's no the in-person box?
Yes.
Yes, that's what I just said. None of the in-person is showing up in that report yet. And Metasket is aware of it.
But you still have to check it.
Yes, you still have to check the box when you're completing a task.
Okay. Are all individuals who receive self-direction Tier 4? My understanding from OPWDD is no. That is a factor in becoming Tier 4, but is not the only factor, and being self-directing in and of itself does not trigger a Tier 4. If someone is Tier 4 and basic, are they subject to the 1 to 20 caseload? No, because when you go to basic, and Jim, you can jump in, you lose your tier rating. So basic would be basic.
Yeah, I think the confusion here was in some of the preliminary roster information we were getting, and staff may have seen that. It was weird, but tiers were showing up for people who chose basic. I think it was on the assumption if they chose the health home care management service that they would have been Tier 4. Now they're actually show on the I believe they come across as Tier 0. Anybody who has chosen basic HCBS plan services.
Thank you. Someone asked about going in and redoing the DDP to change the tier. And definitely you need to be paying attention to the DDPs. We have a number of them that are outdated, which we will be communicating when we get that information on what's outdated. So the DDP should be regularly updated, but we don't recommend, nor should you do a DDP that does not reflect the true scores and the true need of an individual. If the DDP was not done appropriately and was inflated and needs to be done so that it really reflects the true needs, that's one thing. But if we start, we don't want to be presenting information that isn't accurate. And remember, if people are self-directing and that DDP is changed and is artificially lowered and not accurate, it directly affects their PRA score and their ability and the money that's in their budget that's available to them. So we shouldn't be playing around with the DDP scores unless somebody played around with them to begin with and they're not accurate. But we should always be accurately reflecting what people's needs are. If the care manager made several attempts to meet with the individual for a face-to-face and has not been successful, can they just document attempts? Well, you probably won't have another alternative. People can refuse to see you and people can evade seeing you. And that's absolutely what you need to do. Your record needs to demonstrate your attempts or what the response from the individual was in completing that face-to-face. A request, and this is great, and we will get this out for future dates and locations of job fairs. We want to make sure the workforce and individuals asking, make sure that the workforce knows when the job fairs are happening so they can inform as many people as they know, and we definitely will do that. What if you have a degree and no MSc experience? Will you hire and train? Lisa Reese, I'm going to pick on you, who's texting along here. I will repeat the question.
Thank you, I apologize.
If you have a degree but no MSc experience, will we hire and train? We can't without experience.
Well, they have to have relevant, they have to have what we would define as relevant experience, which we're working on defining relevance up until now. Relevance has included experience as a DSP. So in that case, yes, we would hire someone with the appropriate experience and the degree, even though that experience may not be in service coordination. We have done that. People that are with us right now have not been MSCs before, and we are in the process of training them.
Okay, thank you. Someone has an idea of reaching out to schools, graduate schools for recruitment. Thank you. We definitely are. It's on our radar.
That is part of our plan. Without question, it's a great idea.
Somebody over there.
New York have something to say there? I hear a little.
We were just. Rachel's trying to trade credit for that idea.
It was my idea yesterday. I shared it with Megan. I didn't type it in.
Oh, please, Rachel. It's not even from your area of the state. Anyway, okay. Where are we? Low billing. And now I missed many times case notes are just not entered correctly and should be billable. Staff are willing to identify those and correct them now. Yes, we realize there have been glitches, and your devoted attention to working through this is greatly appreciated. It should be much easier in our future months to come. This is a hard month to get everything in, but collectively we're going to do the best we can. Are there interpretive services for sign language? We are working on that, and it is our responsibility to make sure that you have those services in place when you need them. So please be communicating with your supervisors, and they will communicate up the chain and laterally within the organization until we make sure that the appropriate services are secured for people who need them. But yes, we are responsible if somebody requires that support, so to participate in their regular meetings, to participate in meetings with you if there isn't someone that can interpret for them, or if we try to make sure that to the extent possible that care managers that are assigned with people who need interpretation can sign themselves so they can communicate directly. But if you're not in that situation, communicate with us, and we will get the resources in place to support that individual.
And one point on that, Ann, we actually have a contract with Milneck Services. And again, part of the issue here is we're not in all parts of the state with this yet, and we need to be. But clearly, in the downstate area, we have more, I think right now we do have that ability. We actually have a contract for that service. So we need to probably make that people aware of that availability, just like we're doing with Geneva. So we should get that out.
There is a question about what if the individual isn't deaf, but the family is, and the family needs interpretation services to participate. We will handle that on a case-by-case basis, but we would be very supportive in making sure that the family can meaningfully participate in their child's planning and in their services. So let us know what needs to be arranged, and we will work with you to make that happen, even if it's not the individual directly, if it is a caregiver or parent that needs to participate. What do we do if individuals or families are not responding to our attempts to complete the checklist? I don't have the elements of the checklist in front of me to know how much of that you can complete without their active participation. I guess I would say, unless Megan, you want to jump in on any of that, I would say talk to your supervisor and let's figure out what parts of it need that family or individual participation and how we're going to deal with that if that is the struggle that you're having.
Yeah, and I agree. I mean, I think I think there are some parts we could probably complete, but we are going to obviously need to have their involvement. So definitely talk to your supervisor and we'll try to navigate through those situations.
Does the checklist need to be done by phone? I sent out a letter with the checklist and it has not been returned signed. I was told this, and I was told this is not billable. No, it's not billable if you just send out the letter and the checklist. What is billable is you completing the checklist and with interaction from the individual. So if you have not gotten that return checklist, it's still our responsibility to make sure that we complete it. And if you're, like we just covered, if you're having struggles getting cooperation, work with your supervisor.
But you can do it by phone.
Yeah.
I mean, they could
Yeah,
do this over
they
the
can
phone. It doesn't have
together.
to be a face-to-face contact to complete
Yes.
the check.
Yeah.
Right.
Yep.
The family individual does not have to sign off on it. As Jim and I presented inaccurately many, many webinars ago, we thought because it said individual and family signature on a form that it would actually be required on that OPWDD form. But we were advised that that is not true. That's best practice, not required. How do we add the new person we have to choices? I'm not sure.
I think, are they talking about CCO, like adding a person?
Yeah, I mean, that would happen through
Enrolling a
intake.
person, yeah.
So you would work with the person that, you have to work with the person, our intake coordinators throughout the state, depending on what area you're in, and they would be submitting that paperwork. Okay, someone needing help on the GPS. And again, if you don't know how to work the GPS locator, probably pretty much is, you probably didn't turn it off unless you actively, but someone can help you to check that. If someone has only one tier 4 on their caseload, will the care manager need to go to 20 individuals on their caseload? Maybe, maybe not. Yes, if you have one person, then your caseload has to be 1. But that's where we're going to have to maximize our resources. And I can say it would probably be impossible for a care manager just to have one tier 4 on their caseload. That would not make financial sense or be equitable in terms of supporting people in any way. So either the care manager in that situation will need to take additional people who are tier 4 and other people on their caseload will need to change, or that one person will need to go to somebody else's caseload. And believe me, this was our advocacy with OPWDD and how disruptive these tier 4 expectations are going to be for not only the individuals who are tier 4, but everybody else who might get bumped as a result of it or shifted around. But we have no choice. So yes, if you have tier 4 people, your caseload has to be 20, but you're not going to just have one in that situation. I don't know, Megan, Jim, did you want to say anything additional on that? Because I
No,
know
I
it's a
think,
real big
I think you
issue.
covered it, Ann. That's, that all has to be assessed, with the regional directors and and all, down through the supervisory, chain to kind of come up with how we're going to address this for the 900 or so people, which impacts, as you're saying, has a domino effect on a number of people.
Someone asked about the GPS locator services. Does it just need to be on when you're clocking in and clocking out, or at all times? I would say leave it on at all times. There's no reason, since it's a Care Design New York phone, to disable that. I can understand people in their personal lives with their personal cell phones wanting to be off the grid and not wanting that to be on, so that's completely appropriate. My worry is if you're turning it on and turning it off, that you're going to miss turning it on one time, and you don't want to get caught out there with doing that. So I would leave it on at all times, but it definitely needs to be on when clocking in and clocking out.
Yeah, I just want to add, I've had questions, this is Lisa, I've had some questions about this. I think people's concern around that is, are we tracking exactly where people are because the GPS locator is on? And I can't envision any way possible that we would be able to do that.
Or want to.
Or want to.
Or have the time to.
Or have the time to. So there's nothing really, short of the clocking in and clocking out, there's nothing that the GPS locator,
Well,
perhaps a
somebody's
phone
phone was stolen this last week, and I think that would have helped too, but
yes,
that's
true.
so
I
there are,
suppose it's good. I just don't
it's not
want
for Big
people to
Brother.
feel- right. I don't want people to feel like, well, they drive to the store and on their lunch, and we know that they're at the store because their GPS locator is on, and they're not even using their phone.
That's
just
not
doesn't
what we're
happen,
doing,
and that's
yeah.
not the capacity of these phones.
Okay. If you're having problems logging into Paycom on your iPhone, seek technical IT assistance. Help me at Care Design New York, ny.org. I was blanking out, but there's a question about some difficulty with logging in on the phone. If you're in a sub-basement and your iPhones aren't working well, you're looking for some connection solution suggestions, again, email your supervisor, regional care manager, director. We'll be working with IT. We need to know particularly exactly where you are and what we might be able to do. There are some, you can put a setting for your iPhone to tap into the Wi-Fi instead of just the cell phone reception, but you might need an IT person to kind of go through that, or you could Google it and see how you do it. And that may help in what you're experiencing. There was a message asking us to update Paycom, but since the agency pushed the app to the phone, we cannot do so. Where there be more information is how to update our Paycom. I'm not exactly sure what that means, so maybe you can do that specifically to IT and exactly the issue that you're having, and we can explain that better. Many of the typical OPWDD documents we used are not compatible with our system, i.e. service amendments are not editable on our Chromebooks. Is there a way to resolve this? Yes, IT is acutely aware of that and is working on deploying a solution for that. I know Nancy Shea, our director of training, and some of the IT folks met this, I think it was Monday, and came up with some resources and suggestions and went through the list of challenges you all are having, and this was one of the things that was addressed. So I don't know the solution, but I know they're aware of it and will be providing a solution to the field. Is there a document form that we can provide families who are Tier 4 of why we have to visit frequently? This way they are less hesitant to allow us to visit their home. There's not anything that I can think of readily available. I'm sure our team, Megan and the care manager, regional directors, and Danielle could come up with something from OPWDD, referencing OPWDD to be able to explain that to families. I think that's a great suggestion, and we can make that happen.
Yeah, on that front end, we will not be getting anything from OPW, so we'll have to come up with something specifically for, care design here on that.
Yeah, and it's on my list of things, actually, I wrote down that we do have to work on that. So we'll be working on putting something together to share internally with folks.
Thank you. That and basic, we know we had the request to let families know, and we do, it's one of the things we committed to families that we would put on our website, what to expect from your care manager. And again, I think for basic, it's kind of what not to expect from your care manager if you are choosing basic, kind of what the limitations of that service would be as well. So we are going to work on putting that together. I do not have a CDNY iPhone. So it is my personal phone right now. I will ask for assistance and transferring to the CDNY iPhone. So this is someone I recognize the name, should have a CDNY iPhone. I'm not sure why they don't, but we'll address that. And they have logged off, so I can't address that directly. What is ePaces?
ePaces is a part of the system that we'll have access to is not ePaces in totality, but ePaces is the Medicaid billing system that providers use to submit claims, and it contains some basic data that care managers can access through the Medicaid eligibility verification system portion of ePaces, which is what you would be given access to. It gives you information about an individual's restriction exception codes, so basically what services are authorized for them, and it also gives you information about the coverage code, so the type of Medicaid coverage that the person has, and it gives you information in real time about whether or not an individual has Medicaid eligibility at that moment.
Metasced notes need to be longer. Cannot find my notes that are completed.
If you're writing your note in the comment box, then those completed notes are going to show up on the task on the calendar. You have to open the task from the calendar. If you complete the notes in the attached document, the note document, then you have as much room as you need.
How can I identify which notes aren't billable?
If in doubt about whether a note or a task is billable or not, I would chat with your supervisor.
We've provided, on that front, we've provided sort of sample lists for, and I believe that's been circulated and it's been used in training as to examples of what activities are billable that the staff are providing. So that should be referred to, and if you have questions after reviewing that, yes, bring it to a supervisor. Virtually everything you do is potentially billable. The only issue would be is if it requires, when you get to the need for a face-to-face contact, whether it be a tier 4 person or when we get to the quarterly requirement of a face-to-face. But virtually all of the activities that you're performing on behalf of an individual, virtually all of that is considered to be a billable activity by and large.
When it's a two-way street. I mean, just we had a question of someone looking in choices and putting a correct address into the Metasced file. That is not a billable activity. You would need to have an interaction, a complete exchange of information with a family member, an individual. So almost everything's billable, but not always.
Right.
Okay. If you are,
look, I know we're running out of time. I just wanted to, one of the things, and maybe we'll spend more time on the next webinar, is we really haven't addressed, clinical supports that are available to individuals and families that we need to make the staff aware of, or to identify what those needs might be. So I'm just thinking maybe on the next webinar, I just wanted to put that out there, whether it be nursing supports that we need. We know we've had some situations where that's come up. We now have a medical doctor on part-time status, working with us. So I think we need to spend a little bit of time talking about what are the resources either they need or we have available, and we can do that next week. But I wanted to put that out there.
Questions about the 401k status? Will going to the 501c3 status change the 401k? And no, it will not, so not to worry about that. Questions about tuition reimbursement? Thank you for the reminder. There's so many priorities right now. Yes, we still need to get something out to all of you on that. I know, thank you for the reminder that we're beyond our time, which I know we are. Just going to look through and see if there's anything else. Will people who choose basic be assigned to one care manager? We don't know yet. We don't know how we're going to handle basic for the long term right now. People who go down to basic will probably stay with the same care manager, but there is no guarantee that that will happen. I think we'll definitely be looking at that when we have to come into compliance with our 90 days for the tier 4 individuals. So we'll really be looking at caseload assignments very closely and what makes the best sense at that point. If you don't have a supervisor at your site, you still should have a supervisor and a supervisor who's approving your notes. So there was a question kind of who's approving my notes. If you're in doubt and you don't know who your supervisor is at this point, at least you know what region you're in, reach out to the regional care manager director and they can make sure that you're in touch with your supervisor. I think we'll kind of take a look and see if there is any other, some questions specifically about qualifications and people who might have interest in applying. So please follow up with HR on that. And I think that we'll probably sign off unless New York City, do you have anything else to add?
No, I think we're good.
All right, so we'll take a quick look at the questions and get anything else out that we need to. And thank you, everyone. We'll talk to you next week.